Welcome to our genetics webinar. I'd like to introduce Dr. Stephen Archer, our opening presenter today, and later on we'll be joined by Dr. Lauren Badalato and Dr. Joshua Durbin. Dr. Archer is the director of the Translational Institute of Medicine and holds the C. Franklin and Helen K. Bracken Chair. He's a physician scientist and a practicing cardiologist who specializes in the care of patients with various forms of pulmonary hypertension. After training at the Royal Columbian Hospital in BC and the Minneapolis Veterans Affairs Medical Center, he spent a decade on the faculty at the University of Minnesota, attaining the rank of professor. He then served as Chief of Cardiology and Heart and Stroke Chair for Northern Alberta at the University of Alberta, and Chair of Cardiology and Harold Hines Jr. Professor at the University of Chicago. In 2012, Dr. Archer returned to Queen's University as the Head of Medicine and Program Medical Director for Kingston Health Sciences Center. His translational cardiovascular research has been recognized with numerous awards. So over to you, Dr. Archer.
Thanks very much, Robin. And it's a real pleasure to join PHA, which is certainly a force for good for patients and physicians interested in pulmonary hypertension. So when they call, I'm always happy to oblige. And I'm really delighted, before we go to the slides, to introduce my colleague, Dr. Lauren Badalato, who actually, unlike me, is a real geneticist. So I thought it might be nice for the patients to actually meet the brains behind the operation and someone that is actually trained in genetics. So welcome, Lauren. Thank you for joining us. And then my colleague and partner in crime in looking after patients with pulmonary hypertension here at Queen's University is Dr. Josh Durbin. And Josh is the director of our pulmonary hypertension program and does an amazing job looking after PH patients. So thank you, Josh, for joining us. So this is genetics of pulmonary hypertension, time to test. So what I'm going to tell you as patients or people concerned about people with pulmonary hypertension is mostly practical. There may be some science that may be a little bit off the charts and may not be understood by everyone, but I'll try to keep it at a level that's intelligible. So first, acknowledging my colleagues, Dr. Badalato and Dr. Durbin, who are on here, and they'll answer questions at the end. And I'm going to tell you about pulmonary arterial hypertension, exactly what it is, how we define it, and the value of genetic testing as a guide both to patient management, so how we look after you as patients, but also how we can do better surveillance, make earlier diagnosis, and you as a patient or person in a family with pulmonary hypertension can also make choices in your own life. And then Dr. Badalato will offer the geneticist perspective, because many of you have probably not met with a geneticist before, and she'll be doing slides at the end that talk about how genetic testing is done, how to interpret it, and things that are important for patients when they exercise their choices about what to do with pulmonary hypertension as it pertains to genetic abnormalities. And we were going to hear from a patient, but the good news is that patient is healthy enough that he's working full time and is unable to attend because he's at work. So pulmonary hypertension is very simply defined based on a deviation from the normal pressure in the lung circulation. So as you know, the body has two circulations: the systemic circulation, which is what your doctor measures in your arm, and then the pulmonary circulation, which is in your chest, the purpose of which is to pick up oxygen and get rid of waste. And that circulation, unlike the 120 over 80 millimeters of mercury in your arm, runs at an amazingly low pressure of just 14 millimeters of mercury. So it's an extremely low pressure circulation. And when that pressure is elevated, we call that pulmonary hypertension. So lung circulation hypertension. The definition is anything over 20 millimeters of mercury is pulmonary hypertension. And if we use that definition, which doesn't tell us what type of pulmonary hypertension it is, 1% of the world's population has pulmonary hypertension. So if you think you're alone, you're not. Pulmonary hypertension is very common. If we want to talk about today pulmonary arterial hypertension, meaning the cause of the elevated pressure is obstruction or blockage of the arteries in the lung, that is much more rare, pulmonary arterial hypertension, or group 1 PH. And that is the mean PA pressure is over 20 millimeters of mercury. But then there are other preconditions for that definition, like you can't have left heart disease, you can't have lung disease, you can't have blood clots in your lung circulation. So it's a diagnosis of exclusion. And most of the approved drugs for pulmonary hypertension are for group 1 pulmonary hypertension, or PAH. So here are the 5 categories. Group 1 that we're going to talk about today, where there are genetic abnormalities, is pulmonary vascular disease. So the obstruction is in the arteries, and this is a picture of a blocked artery full of cells. We're not going to be talking about group 2, which is the most common form of pulmonary hypertension due to left heart disease, or group 3, which is the second most common, which is due to chronic lung disease like COPD, or group 4, which is less common due to chronic obstruction of the pulmonary circulation with blood clots like these blood clots that have been removed at surgery. And then there's a group 5, which is a grab bag of miscellaneous conditions. I thought you might be interested to know what we think of pulmonary hypertension as on a more medical basis. So the blood vessels in a patient with pulmonary hypertension are blocked. So you can see this round circle in the top corner is a pulmonary artery, and it's full of cells, and the lumen where the blood goes is just this tiny little red circle in the middle as opposed to this whole big artery. So there's blockage of these arteries. And you can actually see this on an MRI of the lung circulation. See how the blood vessels are cut off, clipped as they come out to the edge of the lung surface. So this is the right lung, and this is the left lung. And these vessels are pruned or clipped off because they're blocked at a molecular level by growing cells that block the circulation. And the right ventricle, which I told you passes blood through the lung circulation at 14 millimeters of mercury, now has to overcome that blockage, so it pumps harder and harder. So this is a patient, there's the left ventricle, this is the right ventricle. The right ventricle should be 1/3 the size of the left ventricle, and yet you can see in pulmonary hypertension it's very big, doesn't contract very well, and that's what causes patients' symptoms, is the right heart failure from trying to deal with an obstructed lung circulation. And we've done epidemiology, meaning looking at the disease in the population, and this is a colleague, Dr. Wijaratney, and we looked at pulmonary hypertension across all of Ontario between 2003 and 2012. We found 50,000 patients. And if you look at the occurrence of pulmonary hypertension over that decade, it's getting more common. The line is going uphill on the blue line. And if you look at the various forms of pulmonary hypertension, group 2 is the most common, group 3 is the next most common, and group 1 that we're talking about today is less common, the least common form. And I'm not going to go into molecular mechanisms, but I'll just tell you of the 11 approved drugs for pulmonary hypertension, 10 of them relate to the function of the lining of the blood vessel called the endothelium. And they're basically designed to be vasodilators that relax the lung circulation. And those of you paying attention will recognize I just finished telling you that most of the problem in pulmonary hypertension is not constriction, it's actually physical obstruction of the blood vessels. So although these drugs are very useful, the sildenafils or Revatios and Adempises and all these other drugs, they don't actually attack the fundamental obstruction of blood vessels. And so knowing the mechanisms on a molecular level that drive the disease is what we try to do as physicians to develop new therapies. And there are some therapies, like a new one, sotatercept, that is coming out that does attack some of the blockage of blood vessel type problem that's going on in the disease. So I just want to talk now about genetics. So you know you have chromosomes, which contain all your DNA, which is the molecule that encodes all the messages to make the proteins that allow you to live. And that genetic code is normally very accurately reproduced and maintained. But sometimes a gene develops a mutation, which is like a spelling mistake. So you see these base pairs, T and A, and you can have one of those substituted and get, instead of an A, a different letter in the molecular code. And when that happens, instead of getting a normal protein like this blue circle, you get an altered protein, or maybe you get no protein, and that can lead to disease. So there are these gene mutations or spelling errors in the genetic code lead blood vessels to grow closed. So they are what drives the abnormal physiology in many patients with pulmonary hypertension, probably in about 20% of patients. And they also cause constriction and they drive inflammation. So depending on what gene, they may cause different problems for the lung circulation. And I don't expect you to remember all this, but what's interesting is that most of these mutations are what are called autosomal dominant mutations with variable penetrance. That's a mouthful, but what it translates to in the orange at bottom is for most pulmonary hypertension mutations, there's about a 50% chance of you inheriting the mutation if someone in your family has it. And that's regardless of what sex you are, whether you're male or female. So it's about a 50-50 chance of getting it. But the variable penetrance is really critical for patients because getting the mutation does not mean you will necessarily get the disease. And in fact, the empowering thing in that is not only that you might not get the disease, even if you have the mutation, but is your own behavior as a patient may determine whether you go on and get the disease or not. So being healthy, not smoking, not being overweight, doing exercise, those things may help you. The list here that I've given you, I don't expect you to remember this, although I think Robin's going to share my slides online. But you can see there are big groups of, there's the bone morphogenetic protein family and receptors that, when mutated, increase the risk of pulmonary hypertension. And you should think of gene mutations like you think of bad cholesterol. They are risk factors for the development of the disease. They're not like your destiny is written and it's automatically going to happen. But anyway, we have the bone morphogenetic protein family. There are ion channels that can be mutated that can cause the disease. Transcription factors, these are factors that regulate the expression of genes, and various miscellaneous factors, some of which our lab has discovered. But a mutation is not destiny. In fact, this is a cover from Time magazine asking the question or making the statement why your DNA isn't your destiny. And it's just a reminder that many of us carry mutations. We don't all get disease. As an example, I'm going to show you in a moment, mutations in a very funny sounding gene called bone morphogenetic protein receptor 2, which is again a mouthful. That's the most common gene that predisposes to pulmonary hypertension. But even if you come from a family that has pulmonary hypertension, and even if you also personally have that mutation, there's only a 1% annual risk for males of developing actual pulmonary hypertension. And it's 3 or 3.5% for females. But the point is, in a given year, you probably, if you don't have the symptoms, won't get the symptoms. And you might go through your whole life and never get the disease. So there are clearly other factors in the environment, things you're exposed to, like drugs, like cocaine, cigarette smoke, your vascular health, that determine whether the mutation will become activated and lead to disease. This is a friend of mine, Bill Nichols, who runs the world's largest pulmonary hypertension biobank, and Queen's University is the one center in Canada that has participated in this largely American enterprise, where they have something like 2,700 patients with pulmonary hypertension from around North America who have all undergone genetic sequencing. And this is some early data from 1,832 patients with group 1 pulmonary hypertension. And it looks at all the pulmonary hypertension, that's the big circle in gray. So 86% of patients have unexplained pulmonary hypertension, meaning they don't have a mutation. 7% of patients have a mutation in BMPR2, and then there are other genes that are mutated. So you can see two things. One is that most patients don't have a known gene mutation. Some of that is we just haven't found it yet. Some of it is you can get pulmonary hypertension with no gene mutation. In fact, if you're a patient that has pulmonary hypertension due to connective tissue disease, chances are you don't have a mutation. But anyway, BMPR2 is the most common. And if you look at it the other way around and say, well, let's talk about all the people with pulmonary hypertension that do have a mutation, what mutation do they have? And you can see 70% of people that have a mutation, it's BMPR2, and then there's a transcription factor, EIF2AK4. These things are all mouthfuls. There's the next most common, an ACVR1. So these are the other mutated genes, many of which only affect 1% of the mutated population. So let's just talk about a patient and why genetic testing. And I think I got this case from Dr. Badalato. So this is a patient I'm currently seeing who's 28 years old. He was referred to me because of an abnormal genetic test. So instead of me making the diagnosis of an abnormal gene, the abnormal gene was discovered because of the family history, and I got asked to deal with the patient. So he's 28 years old, healthy. He had a sister who was older than him, born at the age 2 and died with pulmonary hypertension in childhood. The patient himself is asymptomatic, but smokes a pack of cigarettes a day and uses probably a little more alcohol than he should. And the genetic test showed a mutation in one of the pulmonary hypertension genes called KCNK3, which is an ion channel. And this is how we draw family trees. So we don't know about the dad's history. The mom does not have the mutation, so we assume the mutation came from the dad. This is the sister that died at age 2. This is my patient who's 28 at the time and has a mutation in this gene. And I won't go into the code, but this is describing the mutation. Interestingly, I learned from the patient that he had a brother who also has the mutation, and that brother has a child. And as you predict from the autosomal dominant nature of this disease, where it's 50-50, not surprisingly, that child has pulmonary hypertension. And this is my exam, and I know you're not physicians, but there are things that a competent physician can determine on physical exam. And one of them is that the second heart sound has two components, an aortic sound and a pulmonic sound. And when you're slamming the pulmonic valve shut because you have pulmonary hypertension, it's loud. So this person had a loud second heart sound, the pulmonic component, so suggesting that he had pulmonary hypertension. So the stethoscope still has value even in this modern era. I won't go through the rest because it's medical. And this is an echocardiogram. And if you're a patient that's had pulmonary hypertension, you've had this done. And you can see here the right ventricle and the left ventricle, and his right ventricle is mildly enlarged. And we use the Doppler signal to quantify how much pulmonary hypertension there is as a screening tool. And the echo has no risk to the person. So this is the rest of his history. And what I'll tell you is based on the loud second heart sound and his positive genetic study, I decided we better get a diagnosis and see whether he actually has pulmonary hypertension or not, because he really didn't have symptoms. And his EKG was normal, and his physical exam was relatively normal other than the P2. So when we sent him for right heart catheterization, which is putting a plastic tube into the patient, advancing under X-ray guidance, we found his right atrial pressure was normal, but the pulmonary artery pressure was elevated. You remember the diagnostic criteria of more than 20 millimeters of mercury is pulmonary hypertension. So he has pulmonary hypertension. And this would never have been picked up in the old days. The reason we picked this up is because we looked, and we looked because of a genetic test. And so without going into the rest of his details, I decided, admittedly in the absence of clear evidence, that because he has pulmonary hypertension with a positive family history that was concerning, including a death of a sister, we would start him on treatment. So he got put on amlodipine, which is a calcium channel blocker to relieve constriction, and sildenafil, which is Revatio, 20 milligrams 3 times a day, and has done very well. This is the mutation he has. I know you probably are not interested in this, but this is the ion channel that is mutated, and the dots show where it is mutated. And I just want to point out that what we have to do as groups that, like ours, that try to discover genes, not just administer medicine, but find new mutations, we have to prove not only that we found a mutation, which doesn't exist in the control population, but we have to see what it does. So this is an ion channel, and I know you don't understand these curves, but this is electricity flowing out of a cell. And when you put in that mutation and study how does it conduct electricity, you can see there's much lower black line signal than there is here. So this is much taller than this, and that's because the ion channel doesn't work. And that's the beginning of establishing biologic plausibility. The mutation does something. And I know you also probably will not understand this, but then we can use a technique called CRISPR, and we can edit that mutation into a rodent, like a mouse or a rat. And when you take the mutation my patient has, put it in a rat, what happens? Well, the endothelial cells stop working, the pulmonary arteries constrict, the pulmonary arteries become obstructed, you start making fibrotic tissue, and your heart stops working. So we now know that the mutation my patient has, when you express it in a cell, the ion channel doesn't work. When you express it in an animal, it gets pulmonary hypertension. And so we use grading. Well, I'm almost done with my part. We use this grading system to say, when someone finds a mutation, is it really likely to be causing pulmonary hypertension? So for example, if we look at BMPR, we have the names of the genes across the horizontal axis, and we have the level of evidence on the vertical axis. The higher the level of evidence, the more certain we are that it is a pulmonary hypertension gene. This is done by a friend of mine, Wendy Chung. And basically, the blue is how strong is the genetic evidence. And I won't go into that, but it means this mutation does not show up very often in normal people. So BMPR, very strong genetic evidence. Several groups found it. Doesn't occur much in normal people. And then the orange reflects the biologic plausibility, meaning when you mutate this in mice, they get pulmonary hypertension. This is a gene we discovered here at Queen's University called TET2, and I don't have time to talk about that. You can see our genetic evidence is good, but not as good as the BMPR data, and our biologic plausibility is pretty good, but not quite as good as BMPR. So that's how we decide about genes. It's not as simple as you might think, where a simple spelling error means you're going to get the disease and everyone agrees we should do something about it. I just want, before I go to Dr. Badalato, in some cases, the reason we discover a genetic mutation and we're interested is that you could pass it on to children. In other cases, in addition to that, it also determines how bad the disease is. So for BMPR, this is a systematic study of 1,500 patients with this mutation. They looked at the outcome of death or lung transplantation and all-cause mortality. And what you see, I'm just going to focus for time's sake on freedom from dying. And the people with this is the number of years on the horizontal axis and your cumulative survival. Obviously, you want to be up here at 100% survival. But the people that had no mutation but had pulmonary hypertension did better in the dotted blue lines than the people that had a mutation. So this means even though both groups had pulmonary hypertension, it was worse to have the mutation. And it's often, but not always, true that if you have a mutation and you get the disease, it occurs earlier and is more severe. And freedom from transplantation was the same thing. You were more likely to need a lung transplant in the red line if you had the BMPR2 mutation than if you did not.